The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss advancements in GBM treatment, including tumor treatment fields. This webinar is funded in part by Novocure. My name is Antoinette Tu, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Richard Peterson. Dr. Peterson is a neuro-oncologist who has been practicing in Minneapolis, St. Paul, after completing a fellowship at the University of Washington in Seattle. Dr. Peterson is very active in clinical research. He's involved in developing new treatments for brain tumors, as well as projects aimed at improving the comprehensive care of brain tumor patients. He reviews clinical trials for brain tumors on a local level, as well as nationally, with his involvement with the Brain Malignancy Steering Committee at the National Cancer Institute. Dr. Peterson has also spoken for ABTA on numerous occasions, including our Minneapolis Partners in Treatment and Care meetings. Thank you for joining us, Dr. Peterson. You may now begin your presentation.
Thank you, Antoinette. It's my pleasure to be here today and to be able to talk about this very exciting topic. I think that now more than ever in the past, there are reasons to be very, very excited. It's great to be able to present today and talk about what's going on. So just in terms of disclosures, just to say that I'm not being paid to do this, and I don't have any major stocks or consulting roles. I do have some research that I'm doing here locally that is funded by the company that I work with. This is just to say that I'm not being paid, and there's no endorsement here that's being done by me or by the ABTA. So thank you to the ABTA for this opportunity. Thank you for all of the patients and families and friends and caregivers that are involved in taking care of this what I consider a very special patient population, and I'm happy today to be able to discuss about the advancements that are happening in the world of glioblastoma and how are these eventually going to help us provide better treatments and prognosis, and how can we do these things in a way that minimize the side effects that we see, especially in our world when we're talking about the brain. And I take this very seriously. I'm always saying, how do we protect the brain? Because I mean, it's obviously very important for all of us. And we need to talk about updated therapies. We need to talk about updated devices. So the agenda, as I've laid it out, in terms of therapies, the buzzword is immunotherapy to the third degree. Last year at the Society for Neuro-Oncology, which is our major neuro-oncology meeting every year, the main topic was immunotherapy. If you look at another major meeting that happened this year, it's called ASCO, the American Society of Clinical Oncology, in June. Again, immunotherapy was a major topic. So we'll be talking about immunotherapy and what that means. It's a very exciting topic. It can be complicated. I have some slides that hopefully I'll be able to break this down in a way that makes sense and in a way that helps illustrate why there's so much excitement. We need to talk about devices, tumor treatment fields, most commonly known as the Optune device. We need to talk about advances in what's happening in surgery, and then also with radiation. So I always like to start these talks by saying, this is where we're at. This is the background. How frequent are brain tumors? That in the United States, the frequency, the quoted rate is 21.42 cases per 100,000 people. And I always want to compare this to something else, and usually I use breast cancer. So by way of comparison, breast cancer has 124.6 cases. And when you talk about primary malignant brain tumors, right, so especially glioblastoma, which is the most common primary malignant brain tumor, you're talking about a ratio of 18 to 1. But the mortality for tumors like glioblastoma is roughly 60%. So there's a disproportionate number of patients who pass away compared to other types of tumors, even though it's less common. There's no denying that we have a need for better treatments, and I know this audience would agree with that. So immunotherapy, we're just going to launch into this. There's a long history, and there's a slide I'll show you in a moment that will illustrate that. But if we ask the question, why does our immune system not eradicate these cancer cells, right? Because the immune system is supposed to take care of things that aren't supposed to be in our body. We've had over the years a number of questions about why is this possible, how does this happen? But really in the last 10 to 15 years is when we've really been able to learn more about this and take advantage of it. And at a basic level, immunotherapy refers to any treatment that is designed to induce or amplify an immune response to treat disease. So here's the slide looking at the history of immunotherapy in the setting of cancer. We go all the way back to 1863, where there was a description of immune cells in tumors by a famous physician, Virchow. And you move forward into the late 1890s, and there's this huge gap between 1898 and 1957, right? So almost 60 years where not much has happened, and you start talking about different types of cells in the bloodstream and immune cells, and you start talking about bone marrow transplants, and you move forward to the 1990s where you start learning more about different types of B cells and T cells, and eventually you have vaccines and initial medicines that are being FDA approved in the late 2000s. Now this arrow, this timeline ends in 2010, but I will say that since then, in the last 5 years, there's been an even greater explosion of data and the numbers of types of treatments that have been FDA approved for different tumor types. Now, immunotherapy, there are different types. You can look at what are called monoclonal antibodies, and these antibodies are designed to target specific parts of a cell. Ideally, something that is unique to a glioblastoma that's different from other cells in the body. Vaccines, which can be made from a patient's tumor or, for example, from common components or common proteins or fragments that are found in a particular tumor type. You can modify viruses, or you can target specific aspects of the immune response itself. And we start getting into a little bit of an alphabet soup here. We talk about things like PD-1, T cells, dendritic cells, and we'll talk about this a bit more here. The main players that I'll be focusing on here are dendritic cells, B and T cells, and antibodies. So you see this slide, and this is the complicated version of what can happen with different immune cells. Dendritic cells, T cells, B cells, but I want to break this down into a more simplified version, and that's what this is. If we think about dendritic cells, sometimes we refer to them as the commanding officer, the general, things like that. That the dendritic cell essentially helps direct what the T cells are going to go after. So in simplified terms, a dendritic cell is a cell that could, for example, eat a bacteria, all right? But in this case, we say, well, it could eat or be responding to a cancer cell. So then what happens is the dendritic cell then learns that parts of the cancer cell can be expressed, and then it teaches the T cell to recognize that part of the cancer cell, so then it becomes activated. So this slide really represents a similar representation, thinking about this cell and what's called an antigen presenting cell. And an antigen is just something that is foreign and not supposed to be there. So you have a dendritic cell that is showing this abnormal protein or abnormal thing that's not supposed to be there. And then you again are educating the T cell, which then can lead to developing other types of T cells, especially what are called cytotoxic T cells, which can then attack cancer cells and kill cancer cells, but then can also get the B cells to prevent or to produce antibodies that also can target that abnormality, those features of cancer cells. So one of the things that we think about here is that the B and T cells are kind of the soldiers of the immune system. But then we ask the fundamental question, well, how do tumor cells hide from these cells that are circulating throughout our body? So we then move to the concept of what are called checkpoints, right? So that the T cells especially, if we have T cells that if you imagine are patrolling through the body, looking for things that aren't supposed to be there, you want to make sure that the T cells know what your normal cells look like, because you don't want them just going after your normal cells. So there are these receptors, and this is where we get into some alphabet soup a little bit. There are these receptors on the T cells called PD-1 that will recognize these other receptors that are called PD-L1. And if a cell expresses the PD-L1, right, then they essentially shield themselves, right? So they make themselves invisible, sorry about that, invisible to the circulating T cells. So if you can block that process, then you can allow the T cells to recognize the cancer cells and then attack the cancer cell and destroy it. So the other thing about the checkpoint, the quote-unquote checkpoint, is there are two phases in what are referred to as the priming phase and the effector phase. So the priming phase essentially is using this pathway called CTLA-4, such that if that is activated, then you're blocking the T cell from being able to recognize what it's supposed to go after, right? But if you block that, then you allow the T cell to become activated, and then once you remove the shielding, if you will, from the cancer cell, then it's not only primed, but then it realizes and sees what is not supposed to be there and can attack the cancer cells. Now, these are agents that are already used for lung cancer and melanoma. Not all tumors are known to respond to these treatments. For example, not all tumors necessarily have significant levels of PD-1 and PD-L1 to be able to take advantage of this system. Now, fortunately, we know that brain tumors such as glioblastoma do utilize this system. So again, this is a way of looking at how this works. And I will tell you that the number of medicines that are going to work on this pathway are probably going to continue to grow. There are There are at least 2, 3 that are FDA approved now, but more are certainly being developed and are in the pipeline. So again, if we think about, you know, a cancer cell over here and then a patient's T cells, then if that tumor cell shows that PD-L1, then the T cell thinks that it's normal, it's supposed to be there. But if you block it, then you then activate the T cell so it recognizes the cancer cell and can go after it. And these agents have already been, are starting to enter their way into clinical trials for brain tumors. And so this very exciting line of treatment is coming to our neck of the woods. So it's hard to imagine that, you know, that's just the tip of the iceberg, right? That what I've been talking about is just this one portion of how immunotherapy can go after a tumor cell, right? That you have vaccines and viruses. You have engineered T cells. Obviously, you have chemotherapy that's doing all of this, and you have other agents that can take advantage of antibodies. If we look at the combination of an antibody and a drug together, a form of using part of the immune system, an antibody, and then making that a very targeted sort of treatment, then you lead to this category called ADC, or antibody drug conjugate. And the idea here is that, for example, in glioblastoma, you take a glioblastoma cell and you have this thing called EGFR, which is epidermal growth factor, and the R stands for receptor. Now, 30 to 40% of glioblastoma have an abundance of EGFR. So we could take advantage of that. We can create an antibody that then targets and will attach to the EGFR, and attached to that antibody is a drug called MMAF. Trust me, it's easier than saying the whole long name, which then inhibits the cell from being able to divide and replicate. And whenever a cell cannot divide and replicate when it's supposed to, then you lead to what's called apoptosis, or programmed cell death. So you're using a feature of the cancer cell to create an antibody that's specific to that can then deliver a targeted treatment that kills the tumor cell. The data on this are very promising, and this is in clinical trials for newly diagnosed glioblastoma. Now, if we move on and think about viruses, how can we use viruses to treat brain tumors like glioblastoma? What's nice about a virus, at least in this setting, is that a virus is like a parasite. There's no symbiotic relationship. A virus takes advantage of the cell of the host and uses it for its own purposes to create more virus, if you will. So if you can modify a virus so that it goes after cancer cells, then you can essentially infect cancer cells and kill them, but then you can also use that cell to create more virus and induce more of an immune response to eventually lead to the death of more cancer cells. And ideally, you want to modify the virus so that it targets cancer cells and does not affect normal cells. And as I said, a virus lives to replicate itself using other cells. There's no symbiotic relationship. We can modify the genetic material of the virus so that it uses cancer cells as a replication center. So if we can modify viruses that can also lead to insertion of new genetic information into tumor cells, right? So we can essentially change the message or change the instructions of what that cell does on a genetic level. And then we ask the question, well, what would we want to tell that cell to do? And my favorite response is, well, let's tell it to die, because I think that's what we'd all like to see. So again, this is another way of looking at this and thinking about this, that if you take a virus, and this is a common representation of a virus in a sort of a cartoon way, but the virus gets into a tumor cell and gets into the nucleus where all the genetic material is, the DNA, and causes a response where you produce more virus, and then what happens is, as I said before, that you can then infect other, neighboring glioma cells. So there's a way then of actually using the cancer cell in a positive way. So here's another way of thinking about it, and this is essentially thinking about gene therapy, if you will. What I was alluding to earlier is that you could take, for example, an adenovirus, and you neuter it essentially. So you take out parts of the normal viral DNA and insert something else into it, right? Because you don't want it to be infectious and cause the bad things that a virus might normally do. But you give it some other DNA, some other instructions. The virus then gets into the cancer cell and essentially inserts that new genetic material. So then you can give that cancer cell new instructions, right? And the instructions in this situation would be for the cell to undergo apoptosis, right? Cell death. So you are essentially telling the cancer cell that it's time to be done. It's time to undergo programmed cell death. Do not pass go. Do not collect $200. Do not continue to make more cells and do badness. So there are a number of different viruses out there that can be used, and I'm sure that you've heard about many of them, and they all have some different properties. So some of them seem to have more of a natural affinity for cancer cells, like a poliovirus. Some of them can survive longer, like a measles virus. Some are more amenable to being modified, like an adenovirus. There are an incredibly quickly growing number of studies with different viruses, targets, therapeutic effects. I did a quick look this morning just to make sure I had the most up-to-date sort of information. I went on clinicaltrials.gov just to look for what are the open clinical trials for glioblastoma, and there were 234 results. And I would say close to a third of those clinical trials are for some sort of immunotherapy. Now, 5 years ago, that was a dream. That was a pipe dream. So here we are in a day and age where we're seeing that a vast number of our clinical trials are in this line of treatment, which is incredibly exciting. Now, if we get back to the idea of vaccines, the idea here is that, we're not trying to prevent some disease, like measles, mumps, rubella, that we're trying to create a response in the immune system, directing attack on cancer cells. And there are different types of vaccines. Some of these can be made from an individual's own tumor, and some can be made from parts of cancer cells that are common to that particular cancer type. So if you look at glioblastoma, you could take parts of those cells that are common to most glioblastomas. Now, there are pros and cons to each approach. But let's talk about, for example, a dendritic cell vaccine. So again, the dendritic cell is, like the general or the part of the immune system that tells the T cells and other cells what to do. So what would happen here is a patient with a glioblastoma would then go through what's called apheresis. So you would collect stem cells. You collect cells from the blood, and you would then identify these precursor cells, give them growth factors to get them to turn into dendritic cells. And you expose this immature dendritic cell to properties or proteins of cancer cells, right? So that as this immature dendritic cell is becoming mature and learning its role in the immune system, that as it becomes mature, it knows that these are the things that we're going to tell the T cells to go after. So again, the idea here is that with a dendritic cell vaccine, that you get a person's cells, you induce them into dendritic cells, you then expose them to the things you want them to go after, and then give them back to a patient. Now, you can also create a vaccine from a person's own tumor, right? So you create, you break down glioblastoma cells and give them back to a patient in the form of a vaccine. There's also what are called heat shock protein vaccines, which play a significant role in the immune response and play a role in the way that it actually helps to activate the dendritic cells and the T cells. So you can use a tumor from a patient that has been removed and create a heat shock protein vaccine that then, given back to the patient, really helps to activate the immune response and target glioblastoma cells. There are multiple trials that are open or opening, looking at different vaccines, whether it's a dendritic cell vaccine or otherwise. So what's next? All right. So this is all incredibly fascinating and very, very exciting. But again, this is only the tip of the iceberg. So so as of 2015, we see that there are approvals of medicines for the PD-1, PD-L1, and the CTLA-4, the quote-unquote the checkpoint inhibitors. But then we also want to look at what can we do in terms of combination therapies. And then we also have this other thing called CAR T cells I'm about to tell you about, and looking at vaccines. So, of course, this is the picture that my son wanted me to show, talking about CAR T cell therapy. I showed this slide before, and down here is where we see the CAR T cells, and the CAR stands for Chimeric Antigen Receptors. And what does that mean? It means that we are engineering these cells with specified receptors so that we can target tumor cells without needing a dendritic cell, right? So we skip the dendritic cell part of it and go straight to engineering T cells ourselves that will go after the targets that we want them to go after. Now, so like many things, CAR T cells have undergone generations and evolutions. So again, my son helped me pick these out, but we think about the first generation, the very first kind of CAR. You get to the second generation, and we see updated, newer CARs, vintage 1960s, 1970s. And then third generation, we get to something like the Bugatti, with, which has more potential. If we look at all of these things that are listed here, it tells us that these are the different ways that these T cells can bind cancer cells and create an immune response. So immunotherapy covers multiple types of therapies. The potential here is incredible. Again, the basic idea of being able to unleash our own immune systems to be able to target these cancer types. This is a much more personalized mode of therapy. Again, using a person's own immune system in a way that is beneficial. Ideally, we want this to have less impact on the normal cells because we're targeting cancer cells specifically. And we are seeing dramatic and long-lasting responses from this line of treatment. Now, do we see some problems? Yes, we can. So we see a higher incidence of things like rash and diarrhea. We may see more problems with liver, as well as some endocrine function that we normally don't see with some of our traditional treatments, affecting the thyroid, pituitary, and adrenal glands. Sometimes we can see effects on the lung. Now, another thing that we always have to keep in mind when we're using this line of therapy is that responses can actually take a bit longer. We don't necessarily see them take effect as quickly as some of our more traditional lines of treatment. So we have to be patient with these things. We don't want to abandon treatment too early. We also want to make sure that if we see that there's some inflammation or swelling when we look at MRIs, that we don't want to have a knee-jerk reaction, that we don't want to say, oh my gosh, there's swelling because of tumor growth, that it could actually be because of inflammation from the immune response. And we have to ride that out a little bit and make sure, again, that we're not abandoning treatment too early. So I'd like to shift now to talking about devices, and really that boils down to a couple of things, mostly looking at what's called Optune, or what used to be called Novo TTF, the idea of using tumor treatment fields as a way of treating malignant tumors like glioblastoma. The idea here is that a cancer cell, as it is wont to do, wants to divide and replicate and wants to make more copies of itself. So as a cancer cell goes through that process, the DNA separates, and you start to eventually get to a phase where you start to see that the genetic material is starting to progress towards both sides of the two cells that are to be. Now, if you expose this to an electrical field, what you get is you get a positive charge on one end and a negative charge on another. And what happens with that? Well, opposites attract. So the two halves cannot separate. And as we've seen before, when a cell is supposed to divide and replicate and it can't, it dies. So that process, again, that's called apoptosis. So I left this slide in, and I'm sure many people will appreciate this. This was the version of Novo TTF, what was later called Optune, that we have come to know and love, but just as of a few weeks ago, we learned about FDA approval for the newest version, which I think everyone agrees is an improvement. It is smaller, it is lighter, it's easier to use. I've seen this in person with patients, and it is a significant improvement. All of this, we could say, well, yeah, it looks great. It's lighter, it's easier to use, but all of that doesn't really matter unless it's effective. And so this is the data that came from the study that led to its approval in use for newly diagnosed glioblastoma. We had previously used Novo TTF for recurrent glioblastoma, but the clinical trial that was done looking at using Optune in the upfront setting, so when patients are first diagnosed with glioblastoma, we see that using the tumor treatment fields plus temozolomide after someone has already done radiation and Temodar. So again, our standard of care is to do 6 weeks of combined radiation and temozolomide. Usually we take a 4-week break and then we resume treatment. So patients would not be using the tumor treatment fields during radiation because we couldn't have that on the scalp during radiation treatment. So this is started when we restart the temozolomide, those 28-day cycles, days 1 through 5, the 5 days out of each 28-day cycle, and we see that there's a significant benefit versus just starting Temodar back by itself. This graph here shows what's called progression-free survival. So how long does it take before glioblastoma comes back? And we see that there's a significant separation here that you're talking about at least 3 months. And we look at the tail here, we see that no matter at what time point you see that there's a significant difference between the number of patients that that have gone without progression, without the tumor coming back, compared to using just temozolomide by itself. And then we also look over here at overall survival. So not just how long did it take for the tumor to come back, but overall survival. And we see, again, that there's a significant difference between the two. That we're seeing that on average, if we look at 50% on average, we're getting out beyond 18-20 months for overall survival. And is that good enough? No, it's not good enough, but it is certainly progress. When I started doing this, over 10 years ago, we would frequently say that the average life expectancy was closer to 12 or 14 months, and so we're moving in on doubling that. There's real progress here. Are we where we want to be? No, but this is significant progress. And based on this data, the clinical trial actually ended early, and last fall in October, FDA approved the use of the Optune device for the initial treatment of glioblastoma. So again, we had previously seen efficacy in recurrent glioblastoma when glioblastoma came back, but then now we have an indication for using it with newly diagnosed glioblastoma. And I believe that there was recently an update on what are called the NCCN guidelines. These are national guidelines that physicians use as to essentially say, well, what is the standard of care, and what are the things that we as physicians should be doing in the treatment of our patients. And so the use of Optune now has a more a prominent place in those guidelines. Now, what's nice about this, of course, is that you're not taking a pill, you're not taking a shot, it's not IV, that you don't have typical quote-unquote chemotherapy side effects. That the thing we really have to worry about here is, does this irritate the skin, which is why typically we want to switch out the treatment arrays every 3 to 4 days to make sure that we don't have that skin irritation, and also to make sure that the hair is cut short enough that the treatment arrays can adhere to the scalp. Now, appearance is an issue for some patients, all right? And I've told this story many times. I think when I first saw initial data for tumor treatment fields at brain tumor conferences going back 8, 9 years, I also thought, well, that looks really hokey. Well, here we are. We have clear data, and the data are strong, and you can't ignore those things. So, in my mind, if we don't offer this treatment, then we're doing a disservice. You know, we're withholding something that patients could benefit from, and if the appearance is an issue, then appearance is an issue. I'm certainly not going to force anyone to use it, but I'm going to encourage people to use it. Now, another nice thing about Optune is that regardless of someone's MGMT status, this works. And we talk about MGMT status because we know that if someone has what's called MGMT promoter methylation, that they are more likely to respond to temozolomide, which is the most common chemotherapy that we use. But if someone does not have that methylation, and I'm sure many of you have heard that term, you know, methylation of the MGMT, that without the methylation, that there's a decreased chance that someone would respond to temozolomide. And so Optune works regardless of that. And we see that more and more this is being incorporated into daily practices. Now, let me transition to advances in surgery. Now, as it stands, we think about surgery and how to proceed based on what's the size of the tumor, what's the location, can we only do a biopsy or take out a certain portion of it. We always want to take out as much as possible because it has a bearing on prognosis and treatment. But we also know that surgery is not a cure, that tumor is left behind, and there are many analogies that are used here. You know, these tumors have fingers or tentacles, or, you know, it's like looking for grains of sand on a beach, that you can't see all of them. At the end of the day, what we talk about with surgery is that we want to get a maximum safe resection. We want to get out as much as possible without causing harm, because if one of our patients comes out of surgery with more neurologic problems than going in, then we have done that person no favors. And the extent of the resection or the amount of tumor that comes out matters. The threshold that we commonly use is 70%. If we can get 70% of the tumor out, then that is to a person's benefit. So this is the problem that we commonly face, right? That we see an MRI and we see this abnormality that looks like a glioblastoma, right? And we see that this is after someone gets contrast, and we see that it lights up. And we look over here and we see all of this swelling and edema. And we don't know where the tumor ends, right, and where normal brain begins, because out in all of the swelling, there are going to be some glioblastoma cells. So how can we do a better job of identifying the tumor cells? Well, it turns out that there's this chemical called 5-ALA. It's called 5-aminolevulinic acid, and this is a precursor to the heme molecule. And heme is that part of red blood cells that carries oxygen. And so it turns out that there are certain parts of the body that where you can identify 5-ALA, such as the liver, kidney, skin, but also malignant brain tumors will take this up. So what you can do is you can take this precursor, this amino acid, usually 3 hours before anesthesia, because the body cannot metabolize all of it, it accumulates in certain parts of the body, like malignant brain tumors. And you can identify this by fluorescence. And this is what it looks like. If we look at this picture, during surgery, you can see some areas that clearly look abnormal and clearly look like tumor, right? But again, we don't know where tumor ends and where normal tissue begins. We don't see that there's some sort of border or fine line that surrounds this to tell us where that border is. But if someone takes 5-ALA and you use fluorescence, then you can get a much better sense of where is the tumor, right? And where is there not tumor? And you can even see here that the edges become mixed, right? And this is more vague, right? So you can get a better idea of where to actually try to take the tumor out. So what's the benefit of this? Well, you can potentially improve survival and prognosis by taking out tumor that you would not necessarily know is there on MRI. There's less tumor for us to try to treat with radiation, chemotherapy, other treatments, and you can potentially reduce neurologic impairment from tumor invasion. Now, what's the downside? Well, by taking too much tissue, by being too aggressive and causing neurologic harm, you can have accumulation in liver, kidneys. The skin can be sensitive to light. Not every patient is going to be a candidate for using this because some tumors are too deep in the brain and are really only amenable to doing a biopsy, and a larger resection, a larger surgery is not going to be possible. So when a patient has a tumor where more aggressive surgery is a good option, then this could help maximize removal. Now, 5-ALA has been available in Europe for a while, and we're hoping to be able to have it here in the United States sometime soon. I don't know when, but I know that it is coming. There's also a way of doing minimally invasive surgery using what's called laser ablation. And the idea here is that you're heating the tumor from within to spare the surrounding brain tissue. Now, because it's less invasive, you can potentially access some deeper tumors or tumors that would not be amenable to an open resection. Now, the idea here is that you insert the catheter into the tumor and then you heat it up in a uniform way. But there is some potential damage to surrounding tissue. It can lead to inflammation due to some necrotic tissue. Some patients have had such inflammation and edema that they've actually required surgery as a result. The potential here is pretty broad spread, or widespread and very broad, that it can be used for primary tumors such as obviously gliomas like glioblastoma, meningiomas, tumors that are on the surface of the brain, but also thinking about brain metastases. There are some trials. They're limited. More study is needed before there's widespread use, but this is another very interesting tool in our toolbox that could be used. The last thing I want to talk about is the idea of radiation and what's new and different in radiation. And we think about different types of radiation, right? So we think about what we may be exposed to from working on our computers, and we think about cell phones and microwaves, and we start getting into what's called ionizing radiation, or kind of radiation that can actually do damage to cells, and what's non-ionizing. And so you start getting into ultraviolet, right, because we can get sunburns and skin damage from this, X-rays, gamma rays. Our current use of radiation in treating cancers is in the spectrum of X-rays and also gamma rays. Targets can be larger, can be smaller. Treatments can be done in a number of different ways over days or weeks. Sometimes we hear different terms: external beam radiation, IMRT, gamma knife, cyber knife. At the end of the day, the overriding goal of all of this is to cause maximum damage to the tumor, but minimal damage to the surrounding normal brain tissue. So where do protons fit in all of this? What's the big deal about protons? So this is another form of ionizing radiation, which has the potential to deliver a peak dose of radiation with less harm to the surrounding tissue. And let me show you what I mean. If we use, what we currently use with photons or X-rays, then as the dose of the radiation ramps up, you then are essentially treating tissues that are before the tumor, right? So you're ramping up the dose, and there's exposure to the skin and to some of the shallower tissues before you get to the tumor that's in the brain. And then you also have the tissue beyond the brain that could be exposed. So the idea here is that if you use protons, that the ramp up is different, that you get to your dose and to the treatment area in a much more precise fashion, and then afterwards the fall off is much steeper. So theoretically, the idea is you minimize the amount of tissue that's exposed and treated before the tumor and after the tumor, so the surrounding normal brain tissue. And so we say, well, maximum effect, less harm, what's not to like? Just to give you an idea of what these things look like. So this is a proton beam generator. It's huge. It takes a lot of space and land to do this. This is what it actually looks to a treating physician, staff, to a patient. So this is the debate. Theoretically, potentially, on paper, it looks good. So far, there hasn't been any real clear-cut data to show that it's really any better. There was a large trial looking at prostate cancer, comparing them, and there was no significant difference between them. These are large, expensive, and expensive to build. You need a lot of land and capital to be able to do that. Treatment with protons can be expensive. Sometimes it could be double that of photons, that are currently available. So you have a combination of high expense and not much data to show that it's better, which creates some controversy. Now, there is a clinical trial that is being done looking at treatment for newly diagnosed glioblastoma, looking at the idea of protons versus photons. And certainly in the brain, we want to be very careful. We want to minimize the surrounding normal brain tumor or brain tissue as much as possible. So this is a very important question that we can answer when it comes to glioblastoma. Theoretically, if it works, then you would think more centers will adopt it. Eventually, technology improves. Just like anything else, technology improves, things become more efficient, and cost will get better. We also have to factor in the cost, though, of side effects and complications. If our current treatments create more harm to the surrounding brain tissue, then what is the cost of that? So, in summary, this has been a whirlwind tour of immunotherapy, talking about the potential of immunotherapy, the examples of different types, and what is currently out there and what is coming down the road. An update on tumor treatment fields, the Optune device, showing you the new version, which is a definite upgrade, looking at the data and why this is used. Looking at things that are coming down the road to make surgery more effective, radiation, other devices such as using what's called LITT, the laser interstitial treatment, heating the tumor up from inside. The ABTA offers a service called Trial Connect, which helps to connect brain tumor patients to appropriate clinical trials based on their tumor type and treatment history, which is fabulous. I was on a panel discussion recently talking about how difficult it can be to sort through just even the trials on clinicaltrials.gov and how to navigate through that, and how do you know what's a good clinical trial and which ones are you eligible for. So this is a very valuable service. And as always, thanks to everyone for your involvement, for your attention, and thanks to the ABTA for all the good work that they do and for the opportunity to talk about all of these very exciting things that are happening. So thank you, and I'd be happy to take any questions at this time.
Thanks, Dr. Peterson. Dr. Peterson will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. So again, we're going to go ahead and take questions. We do have a question submitted. Is immunotherapy used in combination with standard of care treatment or in place of it?
Well, actually, both. Mostly it's used in combination with, because really that's, at the end of the day, that's the question that you want to answer is, if we add something to standard of care, is it better than our current standard of care? But if we look at, for example, if we look at patients with newly diagnosed glioblastoma who do not have that MGMT methylation, and so that's the group of patients where we think, well, is temozolomide going to help them as much as if that promoter was methylated? So there are now some clinical trials where we're starting to look at, should we use something else in place of temozolomide in that patient group? And so we're starting to see that approach as well.
Thank you. Another question is, I know you mentioned a few of the promising immunotherapies that have been approved. Do you know when some of the other ones are going to be coming closer to FDA approved status, and if so, which ones?
Well, you have a couple of the PD-1/PD-L1 medicines that are being used in a number of cancer types. We first saw these gaining FDA approval in melanoma, but we now see that these medicines are proving to be beneficial in types of lung cancer, and I believe we're also going to start seeing approval for these medicines in other cancer types, renal cell cancer, potentially breast cancer. But off the top of my head, I'm not sure which ones are necessarily close to gaining FDA approval for all of these different indications. The clinical trials for glioblastoma really are just beginning with a lot of these therapies. We know that some of the vaccines have been in advanced stage phase 3 studies. Some of them have not shown to be as effective as we had thought or had hoped. There are a number of treatments that are currently in phase 3 studies that are fast-tracked. So, for example, there's a dendritic cell vaccine that's being used for newly diagnosed glioblastoma that if it shows promise early enough in the clinical trial that you would actually stop the clinical trial and it would go immediately for FDA approval. You wouldn't even finish the clinical trial if the interim analysis is positive enough. So there are a number of immunotherapies that are in phase 3 trials that show promise and could end up going to FDA approval within even the next couple of years.
Thanks, Dr. Peterson. We have another question. Do you recommend the use of Optune if the patient cannot wear it for the recommended time frame of 75%?
Well, generally not. That's the threshold. 75% of the time is what's felt to be the minimum effective time. So I know what a number of patients, including my patients, will do is they will quote unquote bank time, right? So they'll try to use it more than 75% of the time. And then if they are going on a trip or they have an event that they won't wear it for as long on a particular day, but to go below the 75%, is really below the level of where it's been shown to be effective. So if I have a patient who, for one reason or the other, just isn't able to have the device turned on and powered on and working for at least 75% of the time, then usually we talk about stopping it.
Thank you. And another follow-up question regarding Optune. There was just someone that wanted some clarification. They were told, how long would they be able to use the Optune? Would it be, for 6 to 9 months, or would you recommend it for the rest of their life, or is that on an individual basis?
Well, so I would break it down into two scenarios. Number one, the setting where someone is newly diagnosed. The clinical trial that was done that led to its approval, the way it was set up was that patients would use the Optune for 18 months or until second progression. So, and what does that mean? It means that first progression, the tumor would show, we would see that it's growing, that it's coming back and it's growing. Now, we already know that Optune is approved for that setting, okay? So you would consider continuing the Optune and, if possible, consider clinical trial or consider adding another treatment. But if you see then that it starts to grow again, second recurrence, then you would stop the Optune, because at that point you'd be saying that, really you'd be seeing that treatment is not working, and it wouldn't make sense to continue it. So 18 months or until second progression. Now, in the setting where someone uses it for recurrent glioblastoma, let's say they've never used it for the initial treatment, and they have recurrent glioblastoma, then we continue it until we see that it is not working. So whatever that time frame is, it's indefinite.
Thank you very much. We do have another question. Are there therapies being targeted for tumors that have the IDH1 mutation?
Yes. The answer is yes.
Okay, thank you. Could you also talk about the Duke trial? There's a vaccine used at Duke on a patient with GBM. Do you have any information on that you could share with the attendees?
Well, so I would assume, because there are so many different vaccines, but I would assume that they're talking about the polio vaccine, because that's been in the news. It's been in the news. It's been on 60 Minutes. So obviously very, very promising. I believe it's the data that have been shown on that were from a phase 1 study, so a dose finding and a safety study. The phase 2 study, I believe, is going to be opening soon. So it's very promising. As with a lot of other immunotherapies, you've seen some very dramatic responses. But not everyone has responded, and I think we take a step back and we look at all of these immunotherapies that we still have to be looking at trying to identify the differences in glioblastoma from person to person and trying to figure out which of these elegant, highly targeted, very advanced treatments is going to work for each person, because we know that not all glioblastoma is the same. It varies from person to person. So, the polio vaccine is one of many of these immunotherapies that is out there that shows promise. It's not going to be for every person because they have to have surgery. And depending on where the tumor is in the brain, some patients may or may not be eligible for the treatment.
Thank you, Dr. Peterson. We do have time for one more question. For any inoperable GBMs, are there any other alternative forms of treatment?
Well, that is definitely a group of patients that we want to pay special attention to. So in that situation, we want to try to do at least a biopsy and get at least a good portion of tissue to be able to look at all the different molecular studies, to be able to look at MGMT, IDH, and other things that are coming down the road, to be able to know if someone is going to be eligible for one treatment or another, or one clinical trial or another. But I would say that whether someone has a tumor that can only be biopsied or can have a larger resection, that I think as we move forward, it's going to be less and less about how much was taken out, and it's going to be more and more about what are the features of that particular glioblastoma. So I know personally I have had patients who only had a biopsy and had a lot of tumor, and I would have thought that that person may not do very well just at the onset, but have done phenomenally and had a fabulous response to treatment. And then you see the opposite of that also. And I think really it gets down to not how much of the tumor was taken away or taken out, but what is the exact nature on a molecular, on a DNA level of each tumor, and trying to pick the best possible treatment for each person. So I think that's where the future is, and that's where this is really all moving, not just with glioblastoma, but all of oncology is looking at all of these different factors, looking at what do all of these mutations mean, and how do we take advantage of that, and what do we know about what these tumors do on a molecular level. It's highly varied, and so the size of the tumor and how much is taken out is something that we still pay attention to, but I just think as we move forward, that's going to become less and less important.
Thanks again, Dr. Peterson.
Yes.
That's all the time we have for today. So again, thank you everyone for joining us, and thank you again, Dr. Peterson, for your wonderful presentation and taking time out to answer all of these questions.
My pleasure.
Thank you. Besides our free educational webinars, another ABTA program available to help connect patients and caregivers with information and resources to help support them in the brain tumor journey is the ABTA Careline, which is staffed by caring professionals. You can call 800-886-2282 to be connected with a caring professional at ABTA. Let's pause for a moment to conclude our webinar recording.